Now, I request Dr. Joyshankar Jana sir to enlighten us on a overview on pain blocks, chronic pain blocks. I request now Dr. Vasudha Jadhav madam and Dr. Vinayak Patil sir to chair the session. Dr. Vasudha Jadhav madam, professor and in charge of pain clinic at Bharati Vidyapeeth. She has more than 30 publications under her name. Dr. Vinayak Patil sir is senior most anesthesiologist in Sangli Miraj area, having interest in pediatric, cardiac and regional anesthesia. I request Chairperson sir to introduce our speaker.
Dr. Jana doesn't need any introduction. We all know him. Still, as a customer, I am introducing him. He is MD, DNB, and recently he has done a fellowship in pain management, FIAPM. He is a senior consultant anesthesiologist and pain medicine in KEM Hospital, Pune. He has 4 international and 6 national publications on his name. And his areas of interest are anesthesia for kidney, liver, and uterine transplant anesthesia for advanced laparoscopic and robotic surgery, and pain medicine. He is a governing council member of ISA National Headquarters in 2016 to 2019. Then he was governing council member ISA Maharashtra in 2012 to 2016. He was a past president ISSP Pune 2022. He is honorary secretary of AOA Pune. He is first in Asia and India for anesthesia for uterine transplants, and he is first in anesthesia for cesarean section after uterine transplants. So, over to Dr. Jana.
Thank you, ma'am. Thank you. Thank you. Very good afternoon to all. We are running late in time, so I'll just finish my lecture well in time. So, to all my teachers and seniors and dear friends, I welcome you for this presentation. Many thanks to Vasudha madam and Rupali madam for giving me this opportunity, and of course ISA National. So, with the permission of our chairpersons, can I proceed? So, the topic is blocks for chronic pain in chronic pain management. It's just an overview, because we just cannot cover all the blocks in one small lecture of 15 to 20 minutes. So we'll first start what is the definition of pain. So as per the International Association of Study of Pain, it defines this as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So there can be 2 types of pain, acute and chronic. Acute means less than 3 months, which is directly related to tissue damage. Commonly is post-operative pain, and chronic pain is, according to the definition, is persisting more than 3 months. So then we'll see what is the sequence, how the patient perceives pain. So this is a very common diagram. I don't know how many postgraduates are there. You must know this figure very well, how the pain is transmitted. So first phase is the transduction phase, where is the injury to the tissue. And because of this noxious stimulus, there is activation of the electrical signals and generation of action potential. This tissue damage could be either mechanical, chemical, or thermal. Then comes the phase of transmission, where the action potential developed at the level of nociception is propagated through the axons to the primary afferent neuron. They are carried by 2 types of fibers. One is A delta fibers and C fibers. So A delta fibers are the ones who are lightly myelinated. The conduction velocity is 5 to 15 meters per second, and they transmit rapid, sharp shooting pain, which is well localized. The C fibers are unmyelinated fibers. Conduction velocity is less than 2 meters per second and transmits slow and diffuse pain. So when these fibers transmit the signals into the cell body in the dorsal horn at the level of the spinal cord, this figure is very important. Just see, I'm going through that, which is located in the dorsal horns. These are the first order neurons. They transmit to the second order neurons, so they cross to the second order neurons, and then they ascend in the spinal thalamic tracts to project into the third order neurons in the thalamus, and then they project into the sensory cortex. Then at this level, some fibers also project in the contralateral, that is the same side of the tissue damage, into the periaqueductal area. From here, the periaqueductal gray area, the descending fiber starts. So that is the bulbospinal tracts. Then is a perception, that is a perception of the pain in the somatosensory cortex. and so they discriminate the types of pain, and also the limbic system, which is associated with the emotional aspect of the pain. Then comes the modulation phase. You can see this in the figure. This is descending tracks. So this is the process which normally responds to the body to decrease the intensity of the pain transmission, and this descending pathways play an important role in the modulation. So there could be release of endogenous hormones like endorphins and enkephalins, segmental inhibition at the level of the spinal tract, release of inhibitory neurotransmitters like glycine and GABA. So that's how our gabapentinoids and the gabapins act. Then the descending inhibitory pathways, inhibitory neurons are activated like the serotonin and the norepinephrine, which then gives signal to the dorsal horn and then reduces the intensity of the pain. So classifying the pain basis on basis of mechanism. So what is nociceptive pain? Nociceptive pain is the pain arising from actual or threatened damage to non-neuronal tissues due to activation of nociceptors. Neuropathic pain, pain because of the lesion or the disease in the somatosensory cortex or somatosensory system. What is neuralgia? Pain is distribution along the course of the nerve. What is neuritis? Inflammation of the nerve or the nerves. And what is this nociplastic pain? This is a new term which is classified where the pain is happening but there is no dysfunction of the nerves or there is no damage to the tissue. So this is a new type of the pain defined by the International Society. Now how do you measure the pain? So there are various scales. Only one scale which is commonly used in adults. This is all of them known as numeric rating scale. So from 0 to 10, from no pain to intense pain. Then before we discuss about the various blocks, we must always try the pharmacological way of treating the pain. So very short, so this is the same figure, how the pain is transmitted. So at the level of transaction, you can use NSAID, opioids, and you can block the nerves by using local anesthetic. At the level of transmission, you can use local anesthetics and opioids to block the transmission. At the level of the spinal cord, you can use NMDA receptor antagonist, like most commonly we use ketamine and alpha-2 agonist. But at the level of perception, that is somatosensory cortex, you can use opioids. And at the level of modulation, you can use opioids. And of course, the commonly used drug is tramadol, which inhibits the serotonin and epinephrine uptake. So as per WHO analgesic ladder, so these are the 3 steps. 1, 2, 3. You can go on slowly increasing the type of medication. Now the latest which is added is the step 4. That is the intervention of pain management, where directly you can block the nerve or you can use some modulation of the nerves to decrease the pain. So how do you classify intervention techniques? So this is the classification of interventional techniques for blocks. So regional infusion, neuroaxial analgesia, intrathecal pumps, neurodestructive procedures by using alcohol and phenol, neuromodulation like spinal cord stimulators and TENS, percutaneous we can do vertebroplasties, kyphoplasties, and then radiofrequency ablation. The new adaptation is that, so you have one ascending pathway of increasing the dose of the analgesics, and then we have the descending pathway. So the new additions. So if you know that the pain is localized, and if you give a block directly, the pain is going to be managed. So you give the block directly instead of going in the step ladder form. And once you give the block, you can decrease the dose of the remaining analgesics. Now before giving any block, I'll be discussing the block which normally all the PG students and PG who are doing postgraduate they can give the blocks. So before giving any blocks, you must do all the investigations. So all the investigation, routine investigation should be done. Counseling of the patient is must. You must discuss with them the side effects, the complication and the failure of the block. Written consent about the block. Monitoring and should be attached before giving any block. All aseptic precautions should be taken. Always access IV line, and also discuss the post-block procedure care. What all things should be done once the patient goes home. So investigations, complete blood investigation, acute phase response. Now this is not commonly done when we are doing PAC of anesthesia. We don't do this investigation, acute phase response. So this ESR and CRP is done if to rule out if there is any infection or any inflammation. So this thing is an added investigation when we are doing any block. Of course then blood sugar, HbA1c, renal function, liver function. Other important thing which we must be doing before giving any block is the complete coagulation profile. And then of course the imaging. So you must, in the imaging you can use X-ray ultrasound, CT and MRI, because you must know exactly where you want to give the block. Now, the various types of blocks which are used now, I'll just enumerate and then I'll describe a few of them later. So, if I want to give block for pain arising from head, face and neck, so these are the various blocks. So greater occipital nerve, lesser occipital nerve, gastric ganglion or the trigeminal block, splenopalatine block, stellate ganglion block, cervical facet, median nerve block, cervical epidural. If you are having pain in the shoulder and hands, suprascapular nerve block, acromioclavicular nerve block, glenohumeral nerve block. If you have a tennis elbow or a golfer elbow, carpal tunnel syndrome or carpal tunnel block, deoccurrence block and trigger finger block. So I am just giving an overview. I cannot, because each block can be again discussed for 1 hour. If you have pain in the thoracic area, T1, T2, T3 sympathetic block, intercostal nerve block, splanchnic nerve block, and of course we commonly do the erector spinae block. Then in abdomen, we have the celiac plexus block, superior hypogastric plexus block, and lumbar sympathetic block. So I am just giving an overview. For pelvis and perineum, ganglion implant block and piriformis block. Okay, and then for the spine, from the thoracic, from the cervical area right up to the sacral area. So you can block the facet joint, median nerve block, transforaminal epidural, interlaminar epidural, and then of course thoracic, lumbar, caudal, cervical epidural, selective nerve block, sacroiliac joint block, and of course discectomies, nucleoplasties, vertebroplasties and kyphoplasties. So I will discuss very few commonly used blocks. First is the gastric ganglion block. This is given for trigeminal neuralgia. So if you see the investigations, it is for herpes zoster, cluster headaches, and if there is cancer of the base of the skull, and intractable atypical facial pains. So this is divided into V1, that is the ophthalmic division, maxillary division V2, and the mandibular division. And the symptoms are sharp shooting paroxysmal pain, characterized usually it is unilateral, presence of a trigger zone. The etiology is idiopathic, and the suggestive cause is demyelination of the nerves because of the tumor in the CP angle, or there is grooving of the nerve root. So this is what I discussed, the indications. So this is how we give. So all the blocks in chronic pain is always done under imaging, and it is never done blind. So either imaging could be either ultrasound or CT guided or C-arm guided. So always all the blocks are done under vision. It is never blind. So you can see this is the first. If you see on this side of the screen, it is the submental view. You can see the foramen oval and the needle going through the foramen oval, and that side of the image is the lateral view. So that shows that that needle should not go beyond the slope of the clivus, otherwise you will enter the brain. So that is the importance that you have to always take the images, and then you can do radiofrequency ablation of the gastric ganglion. The next common block, which is very commonly done, you can do it very easily, is the stellate ganglion. Stellate ganglion, the indication when you give is upper extremity block for upper extremity CRPS. Now what is CRPS, if everybody can tell? No students? All have disappeared after lunch. CRPS is chronic regional pain syndrome, sympathetic pain of the head and neck, upper limb circulatory problems. This could be embolic occlusion, Raynaud's disease, or if you give an intra-arterial injection leading to vasospasm. So you, instead of taking a vein, you put into the artery and you inject some propofol or pentothal, severe vasospasm. I have given it many times when the cardiologist is doing angiography through the radial artery. And then they don't know, their hand is getting black and blue, and then they start, hey, come, please come, please come. So this is the way you can give a stellate ganglion block. Initially we used to do it, and when the ultrasound was not there, we used to do it under either blind technique or under the C-arm. But now this is fantastic, it is very easy to do is under ultrasound. Now if you see the image on the ultrasound, on this side you can see the Chasexon's tubercle, that is the biggest tubercle of the C6 spine vertebra. And then if you come here, the carotid artery, the internal jugular vein is compressed because of the pressure, and the longicolli muscle. And if you see on the right side, just above the longicolli muscle and below the carotid artery lies the stellate ganglion. So you can direct the needle in plane approach, and you can deposit the local anesthetic with steroid. So it is very safe now. In fact, it can be even given for intractable ventricular tachycardia on table. Suppose you have a VT on table and is not responding to the treatment, left-sided stellate ganglion block will instantly revert the VT. Then comes the most commonly block which I always give and most of us give is celiac plexus block. Indication, Diagnostic block for upper abdominal pain, not responding to any line of treatment. Pancreatitis, mesenteric artery insufficiency, cancer of the upper part of upper abdominal organs up to the transverse, middle part of the transverse colon. So where do the celiac plexus lie? The celiac plexus lie around the origin of the celiac artery arising from the aorta at the level of L1. So this is how you again confirm your thing by images. This is the lateral view and this is the AP view. So once you confirm the presence of the needle, again you confirm with presence of dye spread. So this is the dye spread. So once you confirm it, then you can inject either, if it is for only for chronic pancreatitis, you inject local anesthetic with steroid. If it is for malignancy, then you can use 70 to 80%, 10 to 15 of alcohol. You can also do it under CT guided. So that's the CT image. You can directly pinpoint the celiac plexus and give the block there. Then comes the most common block also we use is the lumbar sympathetic block. So the indications you can see: circulatory insufficiency of the leg, Buerger's disease, atherosclerotic vascular disease, renal phenomenon, microvascular surgery, reconstruction of the leg, CRPS, phantom limb, and of course herpes zoster. Again the same principle. First confirm the needle placement by AP view and lateral view. Again confirm by using a dye. So you can see the spread of the dye along the anterolateral border of the spine. It has to be given below the level of L2 and L3. You should not give it at the level of L1 because it can cause impotency in case of male patients. Again you can give a local steroid, local plus steroid if it is a diagnostic. And you can, if you want a permanent block, you can use alcohol, or you can use radiofrequency ablation. The next block is a superior hypogastric plexus block. The indications: cancer pain of the pelvic organs distal to the transverse colon. For example, cancer of the prostate or cervix or ovary. Severe endometriosis, excellent results. Grade 4 endometriosis not getting relieved by any, even by surgery, medicines is very good for this. And of course, non-specific pelvic pain. So again, image, confirm. It is just lying at the sacral promontory. So you can go first confirm it with AP image and then lateral image. Again confirm with dye. You can see the nice spread of the dye over the sacral promontory, and then you can inject either local plus steroid or alcohol or phenol. Then comes ganglion-impar block. This is extremely easy block. So when is you want to give indication: cancer of the anus, vulva, perineal areas, coccydynia, and of course post-herpetic neuralgia. Again same, you can see the inverted comma appearance of the dye spread, and once you get this nice image, you can give either alcohol or you can give local plus steroid. Then is cervical epidural. Now cervical epidural, we use it very commonly in our anesthesia practice. Here the patient is sitting and you give it. But in pain practice, it is never done blind. So how we do it? So first we'll see the indications: cervical spondylosis with or without disc herniation, cervical radiculopathy, herpes zoster, and regional cancer pain. So if you see the images, again here the patient is lying prone. After lying prone, in the AP view, you identify the level at which you want to go. Never go above the level of T1 and C7 or C7 or C6. Never give it at C5, C6 level because you have to go below that. So once you confirm that, suppose the patient has radicular pain here on the right hand side. So you don't go midline, interlaminar, you go on the right side in the midline. So you can just like a little paramedian. So once you get inside, confirm with dye spread. You can see the dye spread in the AP view and the lateral view, and in fact you can see the dye spread along the nerve sheath. You can see the nerve sheath, the dye spread. So once you get that, you can give local anesthetic with steroid. Then comes the caudal epidural. Now caudal epidural you are giving every day, either it is pediatric patient or any adult patient. So these are the various indications: pain following trauma, radiculopathy, failed back spine syndrome, lumbar canal stenosis, CRPS, phantom limb, orcalgia, proctalgia, pelvic pain, and of course cancer of the pelvis and perineum. Now here again also we either use ultrasound or you use, before we didn't have ultrasound, so we used to use C-arm. So you can see the nice spread of the dye in the AP view and the lateral view. So in the AP view you can see on that side you can get a Christmas tree appearance. So you can see in fact the dye is coming out from each individual nerve sheets. and then either you can use the local anesthetic with steroid. Now what I'm telling steroid, the commonly used steroid is dexamethasone. So there are two types of steroids. One is particulate steroid and non-particulate steroid. So usually we use the non-particulate steroid, that is the dexamethasone. Then comes, this is a more difficult block, should not be done very routinely unless you are trained you have received the training. So transforaminal epidural injection. So it is indicated for back pain with radiculopathy, secondary to disc prolapse. So the disc has prolapsed and is compressing the nerve, and there is radiculopathy in the leg. Radiculopathy could be secondary to herpes zoster, and then inflammation of the nerve leading to radiculopathy. So radiculopathy could be compression of the nerve or because of infection of the nerve. So that cannot be, so if there is infection of the nerve, you cannot find out where is at the level where it is compressed. So this is the schematic diagram, how you have to go. Between the two spines, you have to go. You can see that blue line, this is called as the Campine's triangle. From here, you enter in the epidural space. Once you enter the epidural space, again confirm in AP view and lateral view. So that is the lateral view. You can see the dye spreads along the nerve sheath. And then you give the local anesthetic with steroid. Thank you. So this was a very short overview. Now people are doing DM in pain medicine. I have covered the entire topic in 15 minutes. So it is impossible.
Very excellently covered, Jana sir.
Thank you, ma'am.
Do you give celiac plexus by transaortic?
So celiac plexus, there are multiple techniques. One is the classical Capi's technique. Capi's technique was there described when there was no C-arm or ultrasound or CT, where at the level of L1, you go from both the sides. The celiac plexus lies on the left side because the aorta lies on the left side. So you go and you give the block. Then once the C-arm came, we could go directly transaortic, go through the aorta. At the level, the first branch is the celiac plexus, or celiac artery. And the plexus lies around the celiac plexus artery. So once you identify where dye spread, you inject the dye. And the third is by using CT. And the fourth is now we are using USG. And the fifth is that which I do commonly now is endoscopic ultrasound guided block.
That block is given by the endoscopist or you?
No, I am only giving it. I had a lecture in last conference. So here the patient, there is no need for the patient to lie in the prone position and all. There is no need for anesthesia. Patient is lying supine. You just put a gastroscope. The gastroscope has a ultrasound. Identify the aorta. Identify the first branch, that is the celiac plexus. By using a fine needle aspiration cannula, you can inject the drug under vision. So nothing is blind.
Very
Thank
good
you.
presentation, sir.
Wonderful lecture and exceptional presentation, sir.
I thank Patil madam for allowing me to take it before her.
I request Dr. Ruta Kulkarni to escort all the dignitaries on dais to felicitation venue. May I request Dr. Senior Sunil Patil, sir, to felicitate all the dignitaries.